Good morning, everybody. As you know, you can type your questions in the Q&A box or raise your hand at the end. And if you have any problems, if you could call or contact Sidoni at that email address. Next slide, please. I'd like to welcome everyone to 2023. This is the first meeting, and we're hosting this session on the unceded and ancestral territories of the Coast Salish peoples. That includes the territories of the Musqueam, the Squamish, the Tsleil-Waututh nations, and the Métis Charter community of the Lower Mainland. And all of you are on various traditional territories. And I think in recognition of all the things that have gone before and all the things that are about to emerge, we need to always remember to respect elders of past, present, and emerging, and the land that we're on. And I know that all of us in 2023 will continue to do the work needed to ensure respect and honor for all the traditions that have come before us. Next slide. So this is province-wide rounds, as you know. This is a collaboration between the University of British Columbia and BC Renal. And we thank all of our corporate sponsors as well as all of the health authorities for all the work they do to really keep our patients and our healthcare providers in the best way possible. Next slide. So I'm going to switch slides and share my screen now. Whoops, it is. Can you all see that okay? Just need a hands up from Brenda or somebody. Yes. All right, great, thanks. So I thought that we would start this year because there's so much exciting happening in the context of kidney disease, and so titled this New Year, New Hope for people with kidney diseases. And to start with, I'd like to just remind people that I have disclosures, which are actually also my perspectives, and I've had the privilege of sitting on a number of data safety monitoring boards, steering committees, and been a participant or a principal investigator in a multiple array of studies, both investigator initiated as well as industry partnered, have been on advisory boards, but also that all of the honoraria are donated to clinical and academic organizations from those activities. But foremost, I remain a clinician, administrator, and researcher in a kind of tripartite attempt to try and balance all of those things. So thank you for listening today. My goals today are to remind this audience, not that you need it, but really just to ground us in an awareness of the burden of kidney disease, practice and implications, review some areas perhaps that not all of you are aware of, specifically some work we've done here in BC about the outcomes of COVID-19 infections in kidney disease patients and how that contributes to the burden, and then spend the majority of it looking at these new agents, SGLT2 inhibitors, not so new, but perhaps new data, as well as non-steroidal MRAs, and ultimately to stimulate discussion and changes in practice. So what is this burden of kidney disease that we all wrestle with? Well, you may or may not know that 850 million people worldwide are estimated to have some form of kidney disease. And for context, the population of Europe is 750 million people. As a cause of years of life lost, chronic kidney disease was number 16 in 2017 and is expected to be number 5 by 2040. Which is not that far away now that we're in 2023. The number of productive life years lost due to premature death or disability in kidney disease is demonstrated on this slide, and this goes from 1990 to 2017. What I want to point out to you on this graphic is these are the different causes of kidney disease: type 1 and 2 diabetes, glomerulonephritis, hypertension, and other, and the number of DALYs lost in millions has increased substantially. And whilst a lot of us think that this is a disease of aging, I want to point out that the bulk of these people are between 45 and 70, and so not necessarily the elderly that many of us think this is for. So as we've all heard, chronic kidney disease affects about 1 in 10 adults. In Canada, that means about 4 million people are living with kidney disease and more than 50,000 are being treated for kidney failure. The 10-year excess mortality risk exceeds about 47%, and between 5 and 10 million people die each year from or with kidney disease. And from a public perspective or a policy healthcare system perspective, as we all know, our patients really do consume a lot of healthcare resources, and that faces a fair amount of strain on both transplant and dialysis infrastructure. And just for some numbers, it costs about $100,000 a patient per year for dialysis. Out-of-pocket costs associated with dialysis amount to about 12% of a patient's income. And costs across the Canadian healthcare system have been estimated to be $50 billion a year. And on top of that, there are productivity losses and additional CPP and private insurance costs that are really quite astounding. And so from a public and health economy perspective, this is really a burdensome disease. And we all know that early identification and prevention of progression is certainly far less costly than dialysis and transplantation, but the costs of these treatments aren't always highlighted to policymakers to make decisions on treatments and investments. And so that's really part of what we've been trying to do of late. These are some American data, but they're not probably that different in Canada. And one of this on your left-hand side is the awareness of people who are varying risks of kidney disease in terms of the proportion of people who have a risk of kidney disease and their awareness. And so about 40% of people who are at higher risk of kidney failure are actually aware, no matter what era this is in. And there's a nice paper by Kathy Tuttle and her colleagues looking at two very large US healthcare systems with about 2.5 million people in them, commenting that albuminuria and proteinuria is only measured in about 15% of people with diabetes and kidney disease, and in only 5% of people who have diabetes and no kidney disease. So as a marker of kidney problems, albuminuria is not necessarily well looked at or vetted. And this is something that even in the Canadian data and the BC data, whilst not as bad as this, is actually not as good as you might think. And it's more like 40% of people with diabetes have a measured albuminuria, which is still not what the recommendations are. And then in the same population, I think this is quite sobering. And whilst this is a general population not referred to nephrologists, you'll see that in 3 different eras, people with diabetes, kidney disease, and hypertension only had a 25% ACE or ARB use. And sadly, over time, whilst it increased a little bit, so did the use of PPIs and non-steroidals, which, as you know, are actually probably kidney harmful, not kidney protective. So this isn't a high-risk group of people. So we're not doing so well in many places in terms of best therapies, never mind the SGLT2s. This is in the early eras, but even in the tried and true, and then harmful is not so great. A reminder for all of us that GFR is not the whole story, and high or very high albuminuria is significantly associated with an increased risk of cardiovascular death, myocardial infarction, and hospitalization for heart failure. And these are splines for urine ACRs to just describe that for you in greater detail. I think it's important for us to remember that's the reason that we measure urine ACR. And these heat maps, which some of us have seen for a long time, and perhaps are newer to others, describe the relative risk by eGFR and urine ACR, reminding us that these are independent risk factors for not just progression to kidney failure, but all-cause mortality, cardiovascular mortality, the risk of acute kidney injury, and of progressive kidney disease, not kidney failure. And I think it's important for us to recall this and remember that that's one of the reasons that we do measure the 2 parameters. And so what does this have to do with COVID-19, you ask? Well, I just want to remind us that whilst we're at the other side of what has been a quite life-changing 3 years, the impact of what happened with COVID-19 and CKD is just being understood. And everyone was affected, all of us. And again, I want to thank this community for coming together so amazingly well over the last 3 years, and all the things that people have done to keep our patients safe, especially the most vulnerable in dialysis units. But remember that COVID-19 did have an impact. And so we've been doing a number of studies to help us understand, and I'm not going to go through all of them today, but we did look at the responsiveness. The good news is that after the third dose, a lot of people, most of our patients, dialysis, non-dialysis, and transplant patients do respond. The effectiveness is very good in that we would prevent infections. But what I want to show you is what happens when people with kidney disease get COVID-19 infection, and what happens to kidney function with people without kidney disease get COVID-19 infections. And this is relatively new work in press or about to be submitted. So this is some work done from our own database, PROMISE, from looking at whether or not COVID-19 infection is associated with progression of kidney disease. This is prepared by our group at BC Kidney Research Unit, led by Dr. Tikasman and Peter Burks. And basically what we did is we looked at everybody in the PROMISE registry from 2020 to December 2021. Those of you will know that that's when we stopped formally testing people. So this is what we know is absolutely proven COVID infection. And we have 571 patients with incident infection and 21,000 who were never infected during this study period. We did an iterative matching without replacement based on a number of important variables and came up with excellent matching variables, eGFR and urine ACR region, because that would matter, vaccination status, because that would matter, and basically came up with a case and a control set, and then looked at causes of kidney disease, as well as whether or not they went to kidney clinic, various comorbidities, weights, heights, etc., and really had a very comparable cohort of 570 cases and 1,500 controls. And basically, to make a long story and an amazing rigorous analysis short, this demonstrated that the duration, we had a very good follow-up of about 602 plus years. The primary outcome was a decline in GFR of greater than 40% or ESKD, which is end-stage kidney disease. And you find that overall it was 5%, but in the cases, it was 6.3 versus 4.5 in the controls. And any other major kidney outcome, which included death, was also substantially higher in the cases. And if you look at this, both unadjusted and adjusted, it's really a quite profound change or impact on kidney function if you ever had COVID. And so put in words, if you look at COVID-19 infections, irrespective of whether they were hospitalized or not, in non-dialysis dependent people with kidney disease, there's an independent association of progression to kidney failure that's 69% higher. And the importance of this, I think, is that if you think about our patients who we see in our kidney care clinics, then we probably need to monitor them a little bit more closely and not be surprised if their trajectory post-COVID changed for any reason. And this may be one of the reasons why we're seeing some altered trajectories in our patients under our care. The other question that becomes or is also important is whether kidney function changes in people with normal kidney function. And again, this is another data set looking at these post-COVID recovery clinics. And some of you will know that these were internal medicine and multidisciplinary care clinics modeled after our kidney care clinics. And people who with COVID had been referred from hospitalized and non-hospitalized patients, most of whom were previously well. They had standardized evaluation with laboratory and questionnaires and regular interval follow-up. And this is just some of the criteria. This was a program that was stood up in the context of the pandemic in an attempt to capture these people who had post-COVID, mostly long COVID that you'll know about from the press. And so this was the cohort, 5,600 people referred to PCRC. Some of them had a GFR prior to COVID and some of them did not. We took that as a surrogate, if you will, for people who may in fact have had other comorbidities, and so wanted to make sure that we followed those two groups differently. You can see that most of these people have quite good GFRs who come to these clinics. They're around a median of 75 to 80. With the pre-COVID, they're slightly lower than people who didn't have a pre-COVID eGFR. As you might expect, these are the weller people, and so didn't have a reason to have kidney function monitored. I'm not expecting you to necessarily see this well, but basically, irrespective of whether you did or you didn't have a GFR on record before you got COVID, there's certainly a change over the time period at 3, 6, and 12 months. So that in essence, and this is probably the crux of it, irrespective of how good your kidney function was, we were able to demonstrate a change in GFR per month after COVID infection that actually was quite substantial. And yes, it was slightly different if you did or you didn't have GFR recorded beforehand, if you were hospitalized or not, and whether you're diabetic or not. But these are changes for baseline. The annual change in GFR over a 12-month period is between 2 and 5 mils per minute in the overall cohort versus the various things, which actually is quite impressive. And I think that even when so we looked at this amortized, if you will, over the 12 months, and then again, in just the people in a smaller subset who had GFRs available at all the time points post-COVID. And again, quite sobering to see that these are changes in GFR. What I'm not showing you is also the change in urine ACR in these people who were previously well. And the bottom line is that what that ends up meaning is that in those people who have post-COVID condition, there appears to be a new burden of kidney disease. So people post-COVID or who are at moderately increased high or very high risk now, depending on urine ACR and eGFR, is somewhere in the order of 40%. And so I think that's important for us to contextualize in terms of needs and understanding within the current changing landscape in nephrology and the things that we actually have to offer. If I had have seen this and realized that there's 40% more new people who didn't have kidney disease before, but now are at risk for various adverse outcomes in the non-context of a changing landscape, I probably would have been more disappointed, but I think we have a lot of hope now. Like cardiology has had numerous studies, the kidney world is now having an increasing number of clinical trials with positive outcomes, and that's what I'm going to spend the bulk of today or this morning talking about. But important to have renewed enthusiasm for both participation and the answers to good questions. We've had a number of landmark approvals over the last few years, and pretty excited that not just the SGLT2s, but more recently the non-steroidal MRAs are now approved in Canada, and we have access to them, although still not a huge uptake. And I guess the big question is, in whom should we use SGLT2 inhibitors, and are they of value in non-proteinuric patients? Those were the kind of questions that we needed to answer more recently. And so I thought I'd review with you as a larger audience here the evidence that supports SGLT2 inhibitors with a focus on the most recent data from EMPA-Kidney and a meta-analysis that was done in the Lancet. This is a summary slide up until EMPA that shows kidney outcomes and hospitalization for heart failure, cardiovascular deaths across a number of different studies without diabetes and with diabetes, demonstrating a benefit of SGLT2 inhibitors, mostly the bulk of the data being in diabetic patients, but certainly those with and without heart failure and those with and without diabetes. And to put this in context, the EMPA-REG outcome study was done in 2015. The EMPA-Kidney study was registered in 2018 after Oxford sent an investigator-initiated protocol to 3 different companies, and finally got it through and then registered in 2018. The various studies over time included those with just diabetes, some with kidney outcomes, some with heart outcomes, or some with combinations. And I've listed them here for you to see the ends and also the bit of the timeline of when they were started and reported on. And as you know, EMPA-Kidney was the largest kidney trial done with over 6,000 patients. And let me spend a bit of time reminding you what that shows us. So this study was designed to look at people in a broad range of patients who were at risk of progression, including those without and with diabetes. We looked at people who had CKD epi estimated GFRs between 20 and 45, irrespective of proteinuria, and those with GFRs that were higher who did have a urine ACR of greater than 22. We did not include people with polycystic kidney disease or transplant patients, and people were randomized 1-to-1 empagliflozin fixed dose of 10 milligrams versus placebo. It was an event-driven trial with a primary composite of cardiovascular death or kidney disease progression defined two ways: as a change of greater than 40%, just like I showed you in the previous observational study, or crossing the threshold of 10, because we started so low at 20, or ending up on dialysis or with a kidney transplant or dying a renal death. Not everybody had to be on a renin-angiotensin inhibitor because this was a non-proteinuric, non-diabetic group in part, and so some of them may not have had an indication or were already well controlled. So important to note that. So this was a CKD population much broader than had previously been looked at by Credence or DAPA, and so gives us a bigger spectrum, if you will, of patients to look at. For those of us in BC and across the country that enrolled into EMPA-Kidney, I'll remind us that we did this during COVID, and it was really remarkable that this dip that you see is when all research closed around the world. And despite that, and the first patient being randomized in May of 2019, we continued to follow patients throughout, and I thank the study coordinators in BC for being so diligent. But these are all the different countries, and the last person was randomized still during the pandemic in April of 2021, and we completed this. The median duration, because it was stopped early, as you know, was 2 years. And in the end, over 6,600 people were randomized, 54% who did not have a history of diabetes at recruitment. 66% had GFRs of greater than 30, but almost half had urine ACRs of less than 33. And 25% had GN as their disease, with 12% with IG and 3% with FSGS, so largest populations of these groups before. On average, these people are 63 years old. A third of them were female. The estimated GFR in the total cohort was 37, and the median urine ACR was 33, as I said, and many without diabetes. This just, again, shows you A1 is the lowest number, the lowest urine ACR, A2 and A3 is the highest, but you can see that every level of GFR, there is a range of urine ACRs. And these are the results that you've seen, the kidney progression or cardiovascular death, where there is a hazard ratio of 0.7. That's a relative risk reduction of 28%, with a number needed to treat of 28, which is pretty impressive. And no cancer drugs that I'm aware of do this. So we should be very excited about this. And this is mainly driven, the primary outcome was driven primarily by the kidney disease progression outcome, which was pretty impressive, as I've shown on this slide, cardiovascular death being less so and crossing 1. All-cause hospitalization was reduced also significantly by about 14%, which is pretty exciting, because if people don't come to hospital either once or repeatedly, that's a good thing for both resource utilization as well as for the patients. And this was not statistically significant for the first adjudicated hospitalization for heart failure or cardiovascular death. That's probably because this group was at much lower risk of these events given their profiles. And so to summarize what EMPA-Kidney showed us is that a massive reduction in kidney progression or cardiovascular death driven primarily by kidney disease progression, impressive all-cause hospitalization reduction, but failure to meet the other two outcomes put forward for a number of different reasons, primarily the lower risk and also a large number of Asian recruits who have a much lower risk of cardiovascular events. And when you look at the key subgroups of interest, whether by diabetes or not, whether by GFR, you'll see that everything lines up favoring empagliflozin. The lower your urine ACR, this crosses 1, but again, the number of events in this group, this is event-driven, is very small in both groups, and so not a surprise. And then when you look at all the different types of kidney disease, whether they have good or bad hemoglobin A1Cs, whether they do or they don't have cardiovascular disease, and whether they are or are not on RAS inhibition, all of these are highly significant and favoring empagliflozin, which I think is very important for us. If you look at the annual change of GFR, and this is what's important to us as providers and most important to our patients, that their kidney function does not get worse. And so here is the chronic GFR slope over the period of time, with the demonstration at 18 months of a flattening of the GFR relative to the placebo group, with the initial dip, which I'll come back to. And when you look at this chronic slope, again, what you'll see where this is the favoring of empagliflozin, this is 0 and this is positive on this side, whether you do or don't have diabetes, irrespective of your GFR and irrespective of your urine ACR, while attenuated, everything favors the use of the SGLT2 inhibitor, which I think is very impressive, given the totality of the data. And so if you look at the other secondary outcomes in terms of progression, disease from cardiovascular causes, and end-stage kidney disease, you'll see these impressive hazard ratios, which I think, and the number of events per year that you would have reduced difference between placebo and the active group. And because it was important to put this in context, there's a large group called SMART-C, which is the SGLT2 inhibitors in patients with and without diabetes, a collaborative meta-analysis. This was published in the Lancet at the same time or the day after EPIKidney came out in New England Journal, and is important because it puts into context some of the studies that I just showed you. And importantly, this was specifically around kidney outcomes, and they looked at 13 trials with different cohorts, those with diabetes and high cardiovascular risk, those with heart failure, and those with chronic kidney disease, irrespective of diabetes. Those 13 trials culminated in 90,000 participants, 15,000 of whom did not have diabetes. And I think that's important for us as we look at our kidney patients. And what this meta-analysis shows, which is the totality of data across all of our studies, is that irrespective of diabetes or no diabetes, there's attenuation of kidney disease progression, irrespective of the type of kidney disease by diagnosis, there's attenuation. For IgA nephropathy, there is now overwhelming evidence, I might suggest, although the numbers are still small, that there is certainly an attenuation, and everything speaks to the importance, although with very small numbers, in other GNs. Acute kidney injury is something that we all struggle with. This is again demonstrating that acute kidney injury is reduced in people with and without diabetes overall, which is great. There are a number of theories and reasons why this might be, but it may well be a renal protective effect, but also if you're not getting admitted to hospital and you're not getting your heart failure, then you might not be subjected to the various things that can cause acute kidney injury, and that might be yet another reason why. But this is certainly good news, because all of us know that events of acute kidney injury will change the trajectory of people's otherwise stable kidney disease. So this is overall cardiovascular death or hospitalization for heart failure. Again, impressive relative risk reduction. And then to try and put this into context, we wanted to look at the absolute effect per 1,000 patient years and look at the events avoided. So this is in people with diabetes and without diabetes. And this is kidney disease progression, acute kidney injury, CV, hospitalization, or death, and then 2 of the side effects or adverse outcomes, which is ketoacidosis and lower limb amputation. And you'll see here that there's a reduction, quite impressive, of 11 events versus 15 with and without diabetes, a reduction in acute kidney injury of 4 or 5 events per year, and cardiovascular death for heart failure 11 and 2. Yes, there's a small instance of ketoacidosis, never without a inciting event. So all of the ketoacidosis events in the diabetics were people who had an acute infection, sepsis, or another event. And the lower limb amputation is a low risk, but this again is a group of people who are at higher risk for this anyways, and there's no signal for either of those in people without diabetes. So overall, in all of the studied populations, the SGLT2 inhibitors reduce the risk of kidney disease progression and acute kidney injury. All of these relative benefits do not appear to be modified by what your primary kidney diagnosis is. And in totality, the absolute benefits exceed any signal of harm in patients with kidney disease. So we should be pretty excited about using these in patients, and now with the EMPA-Kidney in people with non-proteinuric kidney disease as well, irrespective of whether they have diabetes and irrespective of their cardiac disease. And so there are now 3 groups of people, and as many of us will know, our patients often fall into many of these buckets. So these are, it's a sort of false separation, but type 2 diabetes, kidney disease, and heart failure all seem to derive benefits. And the mechanisms, and I know many of you know this, but just to remind us that there's, hemodynamic effects, as well as probably some metabolic effects in tubular protection, as well as effects on blood pressure, extracellular fluid volume reduction, some change and negative caloric balance and weight loss, as well as a change to non-oxidative metabolism, and reduction in uric acid and sympathetic nervous system activity, all of which culminates in what you see in the large trial. So it's nice to have a mechanism as well as the hard outcomes. So one of the things that plagues a lot of us is the SGLT2 and GFR dipping. And so I think it's just important for us as clinicians, all of us, nurses, dietitians, pharmacists, patients, and the clinicians, to understand this dip and what it really means for our patients and how to perhaps contextualize it. So first of all, it's a variable magnitude, and I'm going to show you some of the associations. Many of the studies have characterized the dip in different ways. And so there can be any change of greater than 10%. Some of them have looked at it categorically of 0 to 10%, 10 to 30, greater than 30. And some have looked at it in absolute changes of creatinine, and all of them give you a similar result. So, but I'm going to stick to what most of the studies show. So the average dip is between 3 and 5 mils per minute in all studies. I don't have the EMPA data yet, but this is the most recent. I added to an other slide, the DAPA-HF, but around, you'll see it's 5.4, 3 to 4, 4.2 mils per minute change in GFR when you start the medication. It's multifactorial. It's due to all the things that we know change with respect to tubular glomerular feedback that actually leads to reduction in GFR and intraglomerular pressures, which is what we're trying to get at. But also we reduce blood pressure and peripheral vascular resistance. And there are some interesting metabolic changes that David Cherney and others have looked at with respect to some inflammatory markers and a reduction in evidence of renal oxidative stress, which are probably also good things, not just bad things. And we first saw this dip in EMPA-REG, and then we saw this lovely flattening, just as you've seen in all those other curves. And then every other study showed the same thing, whether you were a non-dipper, an intermediate, or a big dipper in EMPA-REG or credence, looking at different kinds of dipping, you still got that same plateauing afterwards. And there's a benefit on, so irrespective of whether you do or you don't dip, there's actually a benefit. And then this is the DAPA study looking at the acute and chronic, but the dips are greater, as you might imagine, at the higher GFRs versus the lower GFRs, but they still occur. And interestingly, and this was the reason that we decided to fund DAPA early while we were waiting for the pharmacare approval, is that the benefit after the dip appears earliest in the people with the lowest GFR. So it occurs at about 8.7 months is the crossover when your GFR is the lowest, even though you dip first. It's 11 months and 14 months, the higher GFR just takes longer to get that benefit, but all people dip. So when people wanted to make sure that we were understanding this well, there's a lovely in circulation, this post hoc analysis of RCT across 20 countries in DAPA HF. So it's 4,600 patients, people with poor cardiac function, GFRs of greater than 30, elevated BNPs with and without diabetes. And these violin plots, as well as the adjusted, the different GFR initiation, all demonstrate that both people on DAPA and people on placebo dip, but the dips are greater in the people on drug. So importantly, I don't know how well you can all see this, but in the placebo arm, there are still dippers, 21% versus 38%, 6 versus 12, et cetera. So that's the point, that many people have dips, but those on drug have greater dips than those not on drug. But importantly, all the outcomes are improved in those who are on treatment and dip versus those that are on placebo. And funnily enough, the people on placebo who dipped had a worse outcome. And that's important for us to remember. And this is the study that I found the most compelling, which is by Ziad Al-Ali. It's a real world study of people from the VA. So he assembled a cohort of 36,000 people who were newly on SGLT2 prescriptions versus 209,000 people who had new other prescriptions. And he looked at the estimates of dipping and a whole bunch of the different outcomes that are important to us, cardiovascular, kidney, and all-cause mortality. And then what happens if you do or don't continue the SGLT2. So firstly, we can predict who dips. So this is, again, showing you that whether you're on a new drug of any other cause or an SGLT2, there is some dipping, but it's much higher in those who are on SGLT2s versus any other hypoglycemia. People who are Black, women, people with a lower GFR, people with higher amounts of albuminuria, people with a history of AKR, cardiovascular or congestive heart failure, people who are using ACEs or ARBs or on diuretics are more likely to dip, whether that's a dip of 10% or greater than 30%. And I think that that's, so it's good to know who you can predict will dip the most. And this is probably really a reflection of lack of renal reserve potentially. Dipping, however, does not impact the beneficial effect of SGLT2s on either cardiovascular or kidney outcomes. So he then looked at the composite cardiovascular outcome or kidney outcome and looked at the effect accounting for the mediator or independent of the dips being low or high, whether it's a cardiovascular kidney outcome, and you still get an impressive impact on both cardiovascular and kidney outcomes. And then no matter whether you have a high or a low probability of dipping, you still end up having a positive impact if you're on SGLT2 versus not. And most interestingly, because this is a real world study, he was able, or the team with Ziad leading it, was able to look at what happens if you continued the SGLT2 versus discontinued it. And interestingly, for those people who continued on SGLT2, they had despite the dip, had a better outcome than those people who had a discontinuation of the SGLT2. So I think that's important for us as clinicians to appreciate. We've seen this dip before. It looks like every other dip for ACEs and ARBs. This is an older paper by David Cherney and Judith Miller looking at people with well-preserved GFRs, and the difference with SGLT2s is you don't get hyperkalemia. you don't get a cough, and there aren't any other interactions with RAS inhibition. So it's an expected dip. All of the papers that look at dipping, for those of you that have read them, have almost the same conclusion. And I like this one the most, that I tried to make larger. The urge to discontinue, there seems to be an urge to discontinue the SGLT2. Ultimately, the prevention of kidney failure and cardiovascular events should take precedence over excursions in serum creatinine. So basically, rest assured that there really shouldn't be that issue. It's very common within the 14 to 28 days. It's usually less than 30% from baseline. And as I showed you, we can probably predict who's going to dip. I would urge us not to stop the SGLT2. And in fact, given that it's associated with improved outcomes, it's actually probably says that these people are more likely to do well than not do well. I would also suggest that there's no need to measure GFR after or in any sooner time after starting this SGLT2, because unlike an ACE inhibitor, you're not looking for an elevation of potassium, which might be worrisome. And you know there's going to be a dip, and that will only upset patients and GPs. So important. No need to stop if you see a dip. And there are some cautions that if it's greater than 30%, you might want to repeat it and then consider that there may be other reasons, because that is the least likely, that is the more rare event, and perhaps could be explained by other things. So those are some practical aspects of dipping. So just to make sure that we don't leave out some of the newer kids on the blocks, which are renditions of older kids on the blocks, is the non-steroidal mineralocorticoid receptor antagonists are also here to hopefully stay and contribute to this increasing armamentarium. So we know that kidney disease progression is driven by the combined effects of metabolic, hemodynamic, and inflammatory and fibrotic factors. And as we understand the interaction of these things more and more, and how we can take the different agents, just like we try and do different components of immunosuppression for our patients when we're trying to either prevent rejection from transplantation or treat their GNs or their vasculitides. So when we're taking care of people with chronic kidney disease, we need to think about the various aspects that can be addressed to look at kidney disease progression. And you'll remember from medical school that renin-angiotensin-aldosterone system is a quite complex system with multiple enzymes, receptors, and there are available drugs to inhibit enzymatic reactions, as well as bind with receptors. So there are a number of different agents, and the mineralocorticoid receptor antagonists are what we're most excited about most recently. We're very familiar with spironolactone and the Finerenone, but Finerenone, the new one, is a bulky non-steroidal with a very high potency, with no gynecomastia, with a modest increase in potassium and balanced kidney heart impact, and very short half-life, which is interesting. And so it has been now looked at in the context of kidney disease and cardiac disease in people with diabetes. And so I just wanted to quickly remind us about the Fidelity study, the Fidelity pooled analysis, which is a combination of Fidelio and Figaro, which are both in diabetic kidney disease, but Fidelio with kidney outcomes and Figaro with heart outcomes. So Fidelity has 13,000 people with an individual meta-analysis looking at people with elevated urine ACRs and GFRs between 25 and 90. So a pretty large population of people in whom you'll see here a important risk reduction of time to cardiovascular death, non-fatal MI, fatal stroke, or hospitalization for heart failure in this high-risk group, which is impressive. And time to kidney failure also reduced significantly. And interestingly, within this Fidelity pooled analysis, there is a subgroup of people who were also on SGLT2 inhibitors, and the impact and is actually as good or perhaps accentuated if you're on both agents. So important to remember that this is another drug available to us that is now available in Canada. And so we have these new paradigms where the cornerstone of therapy was ACEs and ARBs to reduce progression. but we have SGLT2s and now non-steroidal MRAs to address all of these different components that are part of the reason that our patients have progressive kidney disease, but also progressive cardiovascular disease. So we're protecting hearts and kidneys, and the better you protect the heart, the more you protect the kidneys. So it's really important for us to focus on that. So I started this talk with new hope, new year, new hope, and happy 2023. But I think we now have a way to delay progression of kidney disease and its attendant comorbidities. Before we had our usual cornerstones, but now we have disease modifying agents in the form of SGLT2s and non-steroidal MRAs. There are other things coming too, endothelial receptor antagonists, various other medications that are, and some other variations of how to block aldosterone. We still rely heavily and need our multidisciplinary team and all the people on it. The regular monitoring and understanding of patients' trajectories remains also important, and the regular evaluation of patients so that we can educate them, navigate, and make sure that we have proper surveillance. And importantly, the enrollment into more and more clinical trials, no matter where we are in the province or the country, is really important as we're entering this really new era where we have so many more RCTs and a number of new approvals in our kidney space that will really give us a lot of hope for our patients and a lot of different ways to take care of people both on and off dialysis and pre and post transplant as well. So we have increasing biomarkers. We're learning much more about genetics. We understand now the value of biopsies, not just for diagnosis, but also for prognosis. And the more biopsies we do, the more we actually understand. And with molecular diagnostics, we're able to now look at therapeutic targets in a different way. And that's how some of these newer drugs have been found and looked at. We're starting to appreciate there's novel study designs for complex interventions, and appreciate that we are uniquely positioned in this province to be able perhaps to carry out some of these novel studies and platform trials, look at responders and non-responders and not keep people on drugs that's not working. And these new therapeutic strategies are really exciting, I think, for us. And so, you know, I'm for the rest of this weekend, I'm going to be co-chairing with Paul Stevens the update for the 2023 KDIGO diagnosis, evaluation, and treatment for CKD. And this is the first time we actually have some things to say about delaying progression. The previous iterations were all about diagnosis and evaluation and a lot less about some solid data about what you could do. So that's pretty exciting. And hopefully implementation is the next step. So what I've tried to do in 50 minutes or so is remind us of the burden of kidney diseases and the diagnosis and implications of the different parameters. Give you a little bit of an update of what we've learned about COVID-19 and people with kidney diseases. And I think it's important for us to not just think it's yet another, they got infected and now they're better and that's great. I think we've actually shown in the past in a similar cohort that any infection in a CKD patient actually changes their trajectory of kidney disease, which is important. And then what I've tried to do is go through with you the new care options about and how we can avoid or prevent progression, aka and cardiac events, because that in and of itself will improve our outcomes. And then the newer agents, which are actually targeting the delay of progression, and really how we should time the implementation of these is something that we can certainly discuss. And I just wanted to conclude by thanking the patients and all their families for their patience with us while we work this all out, but importantly for showing up and for actually participating in trials, all the healthcare providers, all of my local and provincial colleagues that support all the work that gets done, and very importantly, the research assistants, statisticians, and methodologists at BC Renal, at UBC CanSolve and BC Kidney Research Unit, and some of the work that I showed you with the COVID stuff was also co-orchestrated with Sunnybrook and the Ontario Renal Network. and the funders through CIHR, Canadian, COVID Immunization Task Force, the Public Health Agency of Canada, and our industry partners. And so with that, I'm going to stop sharing so I can see things and answer questions, but hopefully that gives you a little bit of a feel for where we are in the current era of kidney disease. And I think it's really a time for hope. So I'm going to stop there, and I don't have someone to help me look at all the questions. But if someone wants to ask a question, that's okay. I might also, many of the clinicians will have received a letter yesterday, thanks to Dan Martinussen and Cliff Lowe and Judith Marin and all the people working on the pharmacy formulary committee. But dapagliflozin is now available for people in British Columbia through PharmaCare. It's essentially unrestricted. So that is really good news. And there's a method now by which to ensure that our patients can get on that drug. And so that should, again, lower some barriers that previously might have existed to ordering it. So I'm just going to quickly look at the questions. So there are studies going on as to whether or not SGLT2s would be of benefit in peritoneal dialysis and hemodialysis patients. In DAPA CKD, they did not stop people when they went on to dialysis. So we do have some small data from there. In PD, it makes a lot of sense. But if you think about the importance of preserving residual renal function in any form of dialysis, there really wouldn't be an indication to stop. But again, there's a study called Renal Life Cycle, which is going to review in a more rigorous fashion what happens if you start people on dialysis on SGLT2. So stay tuned for that. The outcomes for different kinds of proteinuric and kidney diseases are proportional to the risk. And that was the reason for the meta-analysis, because the risk reduction is proportional to the risk that you have of having the outcome. And all of the SGLT2 studies have been stopped early. And if you stop studies early, you only get 2 years worth of data, so then you have to extrapolate. So that is where I'm trying to quickly answer some of those questions. And then the last one is elderly above 80. I think it shouldn't really be about age. I think if people who will not benefit from having reduction in heart disease or kidney disease or heart failure. So I think depending on the circumstance, I wouldn't make age a rate limiting step to commencing an SGLT2. One of the questions, Sean, practicalities of coverage for Finerenone. I believe it is in pharmacies across Canada as of November 30th. I believe that it will be, it's like any other drug. You'll have to pay for it unless you've had your deductible. So we don't have any extra fancy ways to get it, but I'm not sure that it is currently available, and most of the private insurance companies will cover it at the moment, as far as I know. There's another question about SGLT2 and type 1. No, in EMPA-Kidney, we enrolled, I can't remember if it's 89 or 169 type 1 diabetics. And then we changed the inclusion criteria so that we will have limited data in type 1 diabetes. That's because of a number of problems, including the real risk of ketoacidosis, euglycemic ketoacidosis. However, it's very small. The absolute numbers in all the studies are tiny. But if you stop your insulin, you will get DKA. And so a lot of education around not stopping is required, but there won't be any large studies that we know of in type 1. I think David Shirley's trying to get some of that off the ground, but we'll see. Let's see if there are any other questions. Does anybody want to ask? It's very hard to. Does anyone want to ask a question out loud or? Guess not. Anyways, I hope that this year in 2023, we have renewed excitement about the things that we can do for our patients with kidney disease, and that we are not shy about starting new medications that are truly disease modifying. There are more studies to come. There are more agents to come. It is a very exciting time. And I think that there's a lot of hope. And so thank you all for getting up early on a Friday morning, and thanks for listening, and have a wonderful rest of January. We're going to have a break from any more rounds this month and start fresh in February. So thanks again for all you do and for listening.